Our last speaker for today is Dr. JafarAlsaid. His talk is titled, Can We Stand Against the Hypertension Tsunami?
First, thank you very much for giving me this opportunity to speak among such distinguished audience. I'm sorry to be the last speaker. I'll promise that I will not keep you late. Okay. So thanks for Dr. Dalia to give me this opportunity to discuss one of the topics that we had been working on for the past 2 years, and we will continue working on. So my presentation basically is based on research, so identifying a problem, introduction, putting the hypothesis of the study, trying to structure the research, collecting data, analyzing the data, and trying to put some conclusions. So as everybody knows that hypertension is the most common cardiovascular disease, the most common risk factors, and it had been affecting most 1/3 of the population all around the globe. The World Health Organization showed that the statistic is 1 over every 3 person living anywhere in the world, from China, Japan, until the States, is having hypertension. So we have around 40%, 35%, best case scenario, all over the world having hypertension. If you look at our region in the Gulf, the percentage is around 25% with whatever had been calculated. If we just expand around the GCC countries, including Iraq, Iran, and Yemen, the percentage is still 24%. But if we go to, let's see how I can use this monitor. Yeah, definitely. Just try to see my pointer. Okay. So if you look at the number of the population, and if you look at the number of the patients, just by simple statistic, currently we have around 11 million patients with hypertension in the GCC countries. And then if we just look at 30 years ahead, which is not too much far, the numbers of the hypertensive patients in the GCC countries will be 15 million. And one of the colleagues said that Bahrain's population is 1.5 billion, so we have 10 times more than Bahrain population having only hypertension. If we extend, including the region, Iran, Iraq, and Yemen, the number of hypertensive patients by simple, the number of hypertension patients by simple calculation is 45 million. We are not talking about hundreds, we are not talking about thousands, we are talking about million patients. And in the year 2050, the number of the patient will be 90 million patients with hypertension. If we go to the economics and the money talks, according to the World Bank, high economic country, middle economy, and low economy. As you can see in this blue shade, this is the cost of the cardiovascular disease. So the major chunk of the health expenditure is going to the cardiovascular disease, and the hypertension is one of the most common part of that economy. In the year 2008, the cost of the cardiovascular disease in middle and low income country cost around $3.7 trillion. We are not talking in million, we are not talking billion, we are now talking into $1 trillion. This graph simply shows the growth of the population in the world. In simple statistic, if the hypertension prevalence still remains the same, and this is the growth of hypertension, by the year 2100, we'll be facing 5 billion patients with hypertension, not million, billion patients with hypertension around the globe. So over the past 50 years, and I'm a physician, our work had been focused more on trying to identify new agents, trying to identify new molecules, where is the new drug, how can we drop the blood pressure, what is the targeted blood pressure. We spent a lot of time in investing in treating hypertension. And even it went to some point when hypertension was treated by surgery. Surgery, they use radio ablation, radiation, or they use heat to damage the nerves around the kidney to drop the blood pressure. It worked for a while, but after a while it failed. So basically there is a tsunami, and that's the topic of my presentation. There's a big problem coming, and we are actually living in a big tsunami. So the solution should be different from giving umbrella to people. So if we keep doing drugs, if we keep trying to invest on drugs, then the final point will be that the finances and the money will go only to drug companies. So basically, there will be a depletion from the economical aspect, from individual aspect, or also from the governmental. So the only person who will be winning is the drug companies. So instead of waiting for the problem to happen, how about trying to intervene earlier, even before having the blood pressure? As we know, blood pressure is one of the multifactorial diseases. Multifactorial, that means 50% is genetic, 50% is environmental. So this disease will not show unless it has both factors, which is the genetic and the environmental. So how about not waiting until having the hypertension present and trying to intervene earlier? So we need to form a way that we can curve the curve from increasing and trying to drop the decline with the growth of the population. Eventually, definitely, the most important thing is reducing the total population in the globe. This will solve a lot of a problem, but this is too difficult to control. But so our portion, or our part will be simpler if we try just to decline the increase in the hypertension patients. So how can we do that? So let's focus on the prevention first. We know that hypertension usually is a disease of adult, and it's mostly disease of elderly people. So how about going to the children, trying to identify the disease early, trying to teach them what is the healthy food, what is the healthy lifestyle, trying to identify the disease in the early stage, even before they feel anything or they feel any symptoms. So that was the base of our research. So our research is basically screening the children in all Bahrain. We didn't do two pilot studies, we didn't do a sampling. We wanted to screen every child living in Bahrain. And the idea is, where can we get these children? How can we catch them? And then the bottleneck is the schools, because every child in Bahrain will go to school. There is no child sitting at home. And then which is the best age that you can discuss it with the children, and they will be like the sponge and absorb what you'll give them and teach them. This is basically the teenagers, middle and high school. So the base of our study is go to every middle and high school in Bahrain, screen every student there, trying to identify who is abnormal, who is normal, give them the education, give them the trend, and use them as a need us to distribute the information in the community, and they will be, in 30 years, the future generation of Bahrain. So we'll try to change the outlook of the disease by trying to change the understanding of our children. So the primary objective of the study was basically to screen, to see what's the prevalence of high blood pressure among children, basically teenagers. The second, create a NIDAS who are educated, well-known, understanding children who will be the future generation of Bahrain. And also these children will work in their families and among their friends and their community to distribute the information about what is the health lifestyle, how can they reduce the blood pressure. And on the other side, we had been depending all the time on studies done in Europe and the States. We had been using calculators for risk factors, which does not work in this part of the world, because these calculators had been studied and put on a generation who are differently genetic and differently environmental. So we cannot go and use an equation which is done in the States or Europe and try to implement it on our population, because neither the genetic is the same nor the environmental are the same. So this will be the need as to create the calculators to identify the cardiovascular risk factors for our population. The difference, I'll not go into more medical terms, but the diagnosis of hypertension in children is slightly different, because we don't use only the blood pressure. We have to incorporate that with gender, incorporate that with height, and incorporate that with age. And then there's a percentile with same tables we use, and we try to find if the child is, or the teenage is hypertensive or not. And these are the tables. Basically, there are boys and girls, there is age, there is height, and there is the centile. According to the blood pressure, we can see if he's hypertensive, or she is hypertensive, or normotensive, or normal. So it had been identified by international studies that the hypertension among adolescents and teenagers is underdiagnosed, because they are usually asymptomatic. And even the physicians, when the child comes to the hospital or to a clinic, we don't think that measuring the blood pressure is something important, because we know that's a disease of elderly. Why should we bother and spend time checking the blood pressure? So that's not right. So if we go to studies, this is a summary of all the studies, and just try to focus on these. These are the prevalence of studies have been done on the same age, teenagers. In the States, the prevalence of hypertension is around 2 to 3%. Turkey, they presented like 15%, and this is the pre-hypertensive. That means before getting the blood pressure high, between 15% to 18%. This is just a background so that you can see what is the percentage of the cohort that we have studied. We didn't get any grant, but there was some devices that had been donated to us so that we can do the screening. All the devices are automatic blood pressure devices, and they have been standardized to make sure that we obliterate and remove any variation in the study. And we had all the people who worked in the study are volunteers, physicians from multiple hospitals, nurses, and we also had students who educated them about the blood pressure, and they were participating. These were IB students, very high achievers, on the 11th and on the 12th grade. They were very interested in blood pressure, and actually one of them have presented her seminar and her thesis on hypertension in her school. So these are basically the needs that we were looking for to create the education to distribute it in the community. And basically, the study is a non-interventional, so we just go to a school. After we do the communication with the administration, get the consent from the administration, and get the consent from the family, because we cannot do anything to these children or even go to the school without a consent. So we get both consents from the administration and get the consent from the family, and then go to the school, assign one day where we screen every student in that school. So the students who were excluded are students who were not consented, and the schools were excluded if the administration did not give us the approval to go to that school. And we have received support even from the Ministry of Health just to go ahead and do this research, because it will be of a benefit to the whole country. And the ethical approval was done in 2015. And this is the scheme of the work. So we go to the school, we introduce the project, we give them the idea, and then we get the consent from the administration. They distribute the consent to the family. We get the consent from the family. We assign a day. We go assign the team. We go to that school. We check height, weight. We check waist and the BMI. And then we check the two measurements of blood pressure. Usually the blood pressure, if any of you have had an idea, is a very continuous variable. So that means every second the blood pressure is different. So for that reason, we had the child to sit for 3 minutes, check one blood pressure, and then sit for another minute and check the second blood pressure, which would be the most close to the normal, and then we take the second one for the analysis that will show. We get the data, and then we generate basically forms, and we generate names of students who have abnormal blood pressure. We send these forms back to the administration so that they can send a note to their families asking them to get these children back to their private physicians just to make sure that check their blood pressure and look after their lifestyle if there's anything needs to be changed. And also we send the same list to the Ministry of Health to make sure they have some health education related to school to follow that this child had been addressed, to make sure that this child have received the attention that is required. These are the schools that we finished, 13 schools, and these are the schools that they did not give us the approval to go through and do this study. And this is just a scheme. I'm sorry, it's not that clear. This is the abstract that we distribute to the school to get the approval. And this is a consent form that we distributed. I'm sorry for the small fonts. And for the standardization, we have to have every student sitting. His legs should be on the floor. He should not be jumping, playing with his mobile, and that's the most difficult thing, to have these kids sitting without playing and chatting on their mobiles or the other people jumping around them. That's the most difficult part in that task, I'm sorry. And also the blood pressure should be checked from only one arm, which is the left arm, and there's 3 minutes rest, and then 1 minute rest, and the second blood pressure will be checked. So, and this is a scheme of the education that we have given to these groups just to show them what is the importance of hypertension, how hypertension is checked, and what problems can it cause if we don't treat it. The important thing in children when we check their blood pressure is to have a size of a cuff which is suitable, not too small, not too big. Otherwise, our measurement will be inaccurate. And this is a floor plan that we distribute before we go. So we have a registration desk. There should be sofas so that the student can rest. And then there is the stations where the height, weight, and the waist will be checked. Another place for rest to make sure that they are calm. And then the stations for the blood pressure. And this is a picture from different schools, and this is what it's called the D-Day. You can see everybody jumping, making sure that we meet the time. On the other side, we need to make sure that the students are as calm as possible and to get their blood pressure. If we find one measurement which is not normal, that the child is kept on the side or the teenager is kept sitting for 15 minutes, a rechecking is done after that to confirm that the number is inaccurate or high. And this is an example of one of the schools. What is in yellow is the pre-hypertensive. That means the higher blood pressure, but not in the hypertension. Imagine that a student going to a school, a teenager, having a systolic blood pressure 160 millimeters. and having a diastolic blood pressure 100. These are students, basically, going to a regular school and the rest. So these are asymptomatic people, or asymptomatic students. And these are a sample of one of the schools that we went to. So the final result, the total schools that we have screened and I'm presenting today is 13. The total students, the teenagers, are 2,467. The average age is around 13. Half were males, half were females. The weight, mean weight was 56, and the BMI was 22, and the mean waist was 73. 59, around 60% were Bahraini, 40% were non-Bahraini, which is matching of the previous data that had mentioned Bahrain is half-half. So this is basically a representative population of what is actually living in the country. And this graph, this table actually shows this is the total population, and this is the males, the females. And these are the difference in the males were 1 year older, they were taller, slightly more heavier, and the BMI was bigger in the males as compared to the females, but the waist was similar. And this is a scattered plot of all the blood pressure has two components, systolic, which is the high part, and the diastolic, which is the lower part. So this is a scattered plot of the systolic, which is the higher blood pressure. And the red line I drew here is the cutoff for the normal. So all the dots above that normal are abnormal readings for the students. So imagine it's almost, 50% of the students have numbers higher than the numbers that should be. And this is a scatter plot of the lower type of the blood pressure, which is the diastolic blood pressure. And this line is the line for the normal, and there are still many dots above the normal line. And just imagine that these are students on a regular school day. And the interesting thing in the finding, if we divide this group into age groups, you can find that this is the age by year. You can find the correlation is negative correlation. And this is a very interesting thing, because we thought that with aging, the blood pressure goes. But actually, the cohort that we studied, the higher blood pressure is among the youngest students rather than the oldest. So in the 10th year, 11th year, 12th year, have higher blood pressure than the teenagers who are in the 16 and 18. So this is completely different than what we expected. And that's the systolic, and this one also the diastolic. Same, the correlation is negative with a very high significance. That means the youngest generation, the youngest students have the highest blood pressure, which is the more dangerous part. And these columns represent systolic blood pressure, which is the high blood pressure, diastolic, lower blood pressure, and that's the pulse rate. And this is something called pulse pressure, which is the difference between both and the mean pressure. Between the males and females, the only difference was the females have higher pulse, but the blood pressure was almost similar. So now in this column, whatever is green is good, whatever is red is bad. So the normal blood pressure among the 2,400 were only 47%. 53% of the students have abnormal blood pressure, whether it falls in the pre-hypertension or in the hypertension. When we go to males and females, these two columns shows the males and these two shows the females. We can find that the females have more abnormal blood pressure. So almost 50%. If you go back to what I've shown you from the international studies, 2%, 3%, and even in Turkey, 15%, and now we are talking about 50%. So 50% of our students, our children who are going to schools have abnormal blood pressure. And now if we divide the blood pressure, classifying the blood pressure into the pre-hypertensive and hypertensive, this is the total. So 40% of them fall in the hypertension, not even the pre-hypertension, although the studies showed that the pre-hypertension should be more prevalent than the hypertensive. And for the males, the same. For the females, is the same. In other words, that the students that fit the criteria of having a blood pressure in the hypertension, abnormal, is more than those who are pre-hypertensive, developing hypertension. And when we divide, the blood pressure has stages, 1, 2, 3, depending on the severity. So usually now they classify them into 1 and 2. So this is stage 1 and this is stage 2. Even when you classify the blood pressure, and the yellow stands for the pre-hypertension. So even if when you classify them into stage 1 and stage 2, you can find that the severe hypertension is even more than the lower hypertension. So we have higher percentage of blood pressure, we have higher blood pressure among young ages, and we have the severe blood pressure more prevalent than the lower blood pressure. So all the ungood criteria are there. And as we mentioned, the blood pressure has systolic component, which is the high number, and it has diastolic component, which is the lower number. Usually when the person ages, the vessels, which are the blood vessels, get calcified. So the systolic part, which is the highest part, starts to increase. While in the young age, when we have hypertension, we will not have that type of hypertension, but we will have the hypertension of the lower part of the blood pressure, which is called the diastolic, because their vessels are still elastic. When we distributed the cohort according to the type of the blood pressure, we found in our studied 2,500 students that the systolic hypertension is more common than the diastolic blood pressure. That means the type of the blood pressure is somehow similar to the elderly population. So that means the vessels had not been normal in these cohort that we have studied. So they are presenting a pattern of blood pressure which is similar to the elderly hypertensive patients with calcified vessels. And if you look at, this is a sample from one of the international studies from India, it showed that basically in the same age, the diastolic blood pressure is more than the systolic blood pressure, which reflects what I have mentioned regarding the elasticity of the vessels. And this is basically the distribution of the nationalities. So this is the nationalities, and it's amazingly, we went to 13 schools and we found 31 nationality in these schools. So the Bahraini were 59% and the non-Bahraini were 41%. And when we did a univariate correlation to see what are the factors among what we have studied that had been related to the abnormal numbers, and we can find the age that, as I have introduced earlier, I'm sorry, the age negatively correlated with the abnormal blood pressure, the BMI. The other thing, important thing, in this study, we also studied the obesity. We know that the obesity is very predominant in the region. And the thing that we expected that because of the obesity, the blood pressure is high. But in this univariate analysis, it's contradict that because the correlation is negative. That means the lean children are the ones who have higher blood pressure, not the obese children. So the obesity was even different. And the nationality, the non-Bahraini were more than the Bahraini having hypertension. When we lump all these univariate in an equations, which is multivariate correlation, to see which one is still significant and the others which are not significant, the body mass index is not significant anymore in a univariate correlation, and the types of the school are not significant. But still the age, the gender, the waist, the nationality, and the pulse rate is also remains significant. So as a final conclusion from this study, I hope I have shown you the burden of hypertension that is coming, or basically is present, but we are denying. And I hope that I can convince you that if we go and continue doing what we are doing, trying to invest in drug, trying to find the treatment for hypertension, we will be wasting a lot of money. And by the end, we'll be spending most of the chunks of the money trying to track the tail of the elephant. While if we focus our aims, or if we focus our efforts trying to identify and prevent the disease, then we will be saving money, it will be saving lives. And the thing that we could not understand, I mean, as you know, when you do a study trying to answer one question, instead of answering that question, you'll be ending up in 10 other questions rather than answering the question that you start with. So the questions that we could not answer, why young age have higher blood pressure, why the lean students have higher blood pressure, why the type of blood pressure is similar to the elderly type of blood pressure, which is the systolic, and is this 50% really significant? And these students will be checked by their physicians, the abnormal students. And this is basically, as I told you, this is the cohort that we will be following within 5 years, 10 years, 20 years. And this will be a bank for the information that will be probably generating a lot of studies for the future. And thank you very much. Thank you. Yeah, but you're a mother, definitely. Yeah. It's possible. I think I don't have an understanding explanation, but I think it's just assumption that Bahrain is a confined society, so genetic works a lot. We didn't address any genetics in this study, but this is the second step probably that we will think of. And the other thing, there is a lot of consanguineous marriages, so the genetic even is more focused in Bahrain. But the thing behind it, or the idea behind it, please look at your children. And if you go to a physician, or even if you don't go to a physician, just take them to a physician. Please check their blood pressure, make sure their blood pressure is okay. And if it's okay, everybody is normal. The issue is that the blood pressure, by definition, is not one reading. You have to go 2 different readings at different times, and you need to make sure that there is very finely tuned things, that if he's exercises, if he's jumping, if he's excited, didn't sleep at night, had more coffee, had more tea, was stressed, has an exam, all these are factors that affects the blood pressure. So all these should be standardized before you say that the blood pressure is high and, or hypertensive. For that reason, when we did this study, we didn't end up by just knowing the normal and abnormal, but we sent letters to the school so that they can inform their family, because this is our duty. The family has to know that their kid have something maybe abnormal. It could be normal. I mean, at that time we checked it and it was high. But at least please take your child to a physician, make sure the physician check the blood pressure. And this is basically was one of the aims of the study, is trying to catch these children who have abnormal blood pressure, deviate their lifestyle, and see what would happen in 20 and 30 years. And hopefully we can generate a healthy generation for the coming 20, 30 years that will be living in Bahrain.
I have a question.
Yes?
Inshallah. I want to know, you mentioned that the study is a cohort study. And also in your other study in India is a cross-sectional.
That's right.
So why you called your study is a cohort study and not cross-sectional? Because my understanding of a cohort study is a study that repeated over time. And your data collections, is it repeated over time?
This is the step 1.
Step 1.
Yeah,
okay.
We will continue intersecting the same variable, looking
so
at
it's
the
beginning.
abnormal. It's the beginning of the study.
So it's a cross-sectional study leading to cohort study, right?
The beautiful thing in Bahrain that we have a CPR. So all the students' CPRs is registered with us. So we can track whoever is having their CPR with their CPR. And then we'll intersect them when they become 25. We will intersect them when they become 30, and then 40 and 55. And then somebody will continue, because in medicine there is something called cardiovascular risk factors. That's what I mentioned. And
by
unfortunately,
Fringman study, famous study.
Yeah,
Fringman, yeah.
Framingham study is based on population living in Massachusetts, and they were 1,000 person white American living in Massachusetts, and all the world risk factor is dependent on this population, which is a very unique population. So
would you consider you take a Fringman study as a model for your study in the future? Because it's a cohort study.
Yeah, the Framingham study is basically a 50, 60 years study, and now they have their first generation and second generation.
Yeah.
So this is basically the base that we are following. And with the CPR, and I'm sharing this with many other physicians, that whoever is interested to intersect at some point, please help and go ahead and do that. So we are generating basically the base of the equation. So this is the first time that we are doing it, but it will be intersected at this.
It's a beautiful study, really outstanding. It's very valuable. Maybe if you would like to consider, you have the schools, since the schools now, every school, they have, a nurse and a medical clinic. If you can get the schools who participate with you, they collect the same, systolic, diastolic reading for these subjects, participant, and then you could look at it as a cohort. It could become a great, massive study.
Yeah, sure.
Thank you.
Oh, thank you very much.
Have you considered the type of nutrition for students? I mean, for all these youngsters. I mean, meaning the type of food that they consume, or was it implicitly embedded in the lower weight? But sometimes lower weight doesn't mean that the kid is eating a healthy food.
That's right.
So, yep.
Actually, in some of these schools, when we went, a dietitian came with us from the Ministry of Health, and we addressed the food that is provided by the canteen in the schools. Some schools have changed, and this is basically was the base, because we need to change a wave toward normal. Some schools have already changed their food, and we have seen some schools who have very non-healthy school have changed their school to more healthier type of food. We analyzed the food that is in the canteen, but we didn't get to the food that is eaten by the youngster or the teenage at home. This is something that needs to be studied. But if you look at the analysis with the BMI, the correlation was negative. That means the obesity is not the answer. There's something else. genetic possible, but the obesity, what we are, surprised about obese people, kids sitting playing with their PlayStation or something, watching TV, eating snacks. The obesity is not the people who have high blood pressure. The lean people are the ones who have high blood pressure. So that's something which is very important. Sure.
And related to parents, or because I thought the society is going away from intermarriages. So why would we think it's genetic more than, the around us? I'm not going to argue with food because you've just said that it's nothing to do with that, right, with the diabetes. But I think, could it be the climate? Could it be the maybe more stress society? Because was it, I think, Mukhtar studies or something, it shows that or your studies, 28%, we are the most stressed nation in the GCC. And it looks like something to do with salaries.
Okay.
So
yeah.
And it gives me a bit of indication that
right,
it's probably climate more than genetic, because we used to hear that many intermarriages before. Now people start thinking, we used to remember the sickle cells, now they don't, and they do all the testings,
That's right. Yeah, this disease, as I mentioned, it's multifactorial. That means 50% genetic, 50% environment. It's possible, could be environment. But if you look at, there were no similar studies done in Kuwait or Qatar or Dubai. But if you argue about the stress in Bahrain as compared to stress in Dubai, I would vote for stress in Dubai is much more than the stress in Bahrain as a lifestyle. And if the lifestyle in Bahrain is much more stable lifestyle and had been there for several years, so it's not fluctuating the same as the other GCC countries. So it's a stable environment. If it was there from beginning and having high blood pressure, I can argue against that, because even if you go to Gilgamesh, the land of long life is Bahrain. So that means people survived more in Bahrain because of a lifestyle. So that even the elderly percentage in Bahrain are high. So the life quality in Bahrain is not the unhealthy life quality, although it had changed over the past 20, 30 years with whatever we have been seeing from the westernization. But it's still, as compared to the other countries, it's not the highest stressful environment. But I cannot answer that question because, we didn't address it with the study. Yes?
One more question.
Yeah. Calcification of the vein as simple as you have a pump and you have high blood pressure through a pump, and then you put a hose over that pump and keep the hose in the sun. What happens after a year to that hose? It will get basically calcified and stiff to make sure that it can maintain the pressure that is applied. So this is as simple as possible to the vessel. So when you apply high pressure to vessels, to accommodate that pressure, the vessel will get harder so that it will not rupture. Otherwise, it will cause bleeding and rupture.
No other factor like food or whatever.
There are foods, there is genetics, there is diabetes, there is hyperlipidemia, there is kidney disease. All these come together. But aging per se, this is how it works.
I have just one general question. From what I understand, first of all, nobody really knows the real reason for hypertension.
That's right. Absolutely right.
They only know that you have blood pressure.
That's right.
Even the issue of salt, now they're telling you if you eat more salt, it's better for you.
Yeah, that's not right.
So they say. So they say. They said cholesterol. Cholesterol is an issue. That turned out to be it's to do with the liver malfunction rather than the food we eat.
Okay.
So it's not really the food that we're eating. Oil is the problem. The fact that the liver is not functioning as well is the cause, not the food.
Mm-hmm.
So the treatment is in the liver. Some argue that it's the arteries get hardened. Some say that there's some infections and things on the arteries. Right. So it seems to be a complex issue. Stress is momentary, they say.
That's right.
It's not permanent unless you are stressed 24 hours. So it's all confusing to all of us, really. I am confused.
Yeah, let me give you the bottom
So
line.
maybe if
Unfortunately, the research over the past 20 years is commercial researches. So unless I get a benefit from a research, I will not put my money on that research. So if I am a drug company, I will not sponsor a reduced salt research, because otherwise I will not be selling my drug. If I'm the CEO of that company, I will not put funds for that. So the research for the past 20, 30, I'm talking about medical research, is basically financial interest. So we look at the benefit, we look at the drug which costs billions of dollars, and then we want to sell the drug, and then the drug after a while, if you can, I can give you like 10 types of drugs that had been in the market and then pulled after 2-3 years. These drugs, they introduce them, get the benefit, and then all of a sudden a side effect will come and the drug will be pulled back. So for the hypertension, for this first comment, definitely until today, we don't know the cause. Doesn't mean that there's no cause. There is a cause, but unfortunately, we do not know the cause until today. So it will come at one day when we will know the cause. But for the salt, there is 50% of the people who is called salt sensitive. When they eat salt, the blood pressure will go high. The others can adapt. But it doesn't mean that if you eat salt, it will be good. There are studies done in 6 or 7 countries, major countries, and a countrywide. They reduce the salt content, and then their cardiovascular mortality have decreased by 10%. What they did, they increased the taxation on the salty food. They increase the taxation on Pepsi, Coke, 7-Up. They increase the taxation on cornflakes and all this stuff that has high salt, and their risk of mortality have dropped. And the studies are there. These are 6 or 7 major countries. 10% drop in the cardiovascular mortality. And the expenditure from the Ministry of Health is dropping because basically complications are less. Thank you very much. Thank you.